Welcome to the Tarrant County Medical Minute podcast.
Hi, my name is Dr. Omar Selod. I'm the host of the Tarrant County Medical Minute through the Tarrant County Medical Society. Today, I'm accompanied by a good friend, Dr. Rezaie. Thanks for joining us. So today's episode, we've done a bunch of podcasts through the Medical Society, and we decided that we need to do some talking about medicine for the general public, physicians, and stuff like that. So this is our first one kind of diving into the aspects of medical care here so that we can kind of get some information out to the public here. So today's episode is going to be talking about palliative care, its challenges, end-of-life care, hospice, kind of clearing all that up. So please tell us about your journey. Where did you train? Where'd you go to med school? How'd you get into this?
Sure. First of all, thanks for letting me be the inaugural episode on all things palliative care and just for the general public. So I went to the University of North Texas Health Science Center here in Fort Worth through TCOM, the osteopathic school. I graduated in 2006. And then I did my internal medicine training at what's now called Med City Fort Worth. Lovingly still call it Plaza Medical Center.
Yeah,
I can't let it go.
Right?
I can't let it go. And I finished in 2009. I'll say the exposure that there was for medical students and residents to palliative medicine was essentially non-existent. Actually, in 2006, the AMA adopted palliative medicine as a recognized specialty and fellowship at that time. So it is very young in the scope of things. But 2009, I was hired on into an internal medicine group. And probably around 2011, 2012, I was recruited to be a medical director for a hospice agency. And at first, I kind of poo-pooed it. I was like, oh, that sounds depressing. Don't even know anything about this field, So I ended up going and sitting in an interdisciplinary meeting, and I was blown away. I was like, wow, this is actual care people can receive, as they are close to dying. And then also the care that families and caregivers get once somebody dies, And so I was like, wow, this is beautiful. And so I kind of stuck around there, but then because of the huge shortage of palliative medicine physicians in the United States, they had a program where internal medicine or family medicine doctors could just kind of grandfather in and take the board exam without going through the one-year fellowship. So I opted to do that in 2013. And in all the meantime, I was still doing primary care, but things really shifted for me probably in 2016 when I realized that my own home residency program, Plaza Medical Center, did not have a palliative care program to support their patients, and they see the sick of the sick. They see the patients with strokes and cancers and COPD and heart failure, and there's no support there for those patients. So I kind of grassroots went around to doctors saying, hey, I'm certified in palliative medicine. I'm here to support your patients and you while you're taking care of them. And then now it's evolved into an actual committee that we have with two wonderful palliative care coordinators. And we have, all the components of palliative care committee who can help out patients. And now where I am is I'm full-time as the palliative care physician for the Center for Cancer and Blood Disorders, which is one of our local and community-based oncology groups in Fort Worth, actually DFW. So, yeah.
Awesome. So, you were very helpful when my father was kind of at the end stages of his life. Me and my sisters, we had a lot of questions,
Mm-hmm.
I remember in training, right, everything was like, okay, you're in the hospital, you're sick, go to hospice, or you're going to rehab, right? Like you're going one of these roads, basically, or you're going home. All these words start coming up: palliative care, end-of-life care, hospice, what that triggers, what that entails. And I would call you a lot, and I'm very grateful for that. And my sisters, too, they speak highly of you all the time because, it's the worst moment of life when you're about to lose a loved one, a parent.
Yeah.
And what decision are you going to make that's in their best interest? And what does that decision entail? So let's start with palliative care. Like, what does palliative care mean relative to end of life care in hospice? What does that mean?
Yeah. So palliative medicine is the field of medicine that focuses on alleviation of suffering. And suffering can look so many different ways, whether it's physical symptoms, emotional symptoms, spiritual, existential, financial distress. But basically, as the World Health Organization defines it, it's alleviation of suffering from symptoms related to any potentially life-limiting illness, heart failure, COPD, cancers, dementias, whatever. And it's a multidisciplinary effort. So it's physician, it's nurses, it's social workers, chaplains, therapists of any sort, who are involved in not only patient but also caregiver or patient plus family. That's the treatment unit, to make sure that they have the best quality of life while they're receiving life-sustaining treatment. So while they're receiving chemotherapy, while they're getting surgeries for XYZ problem, while they're getting dialysis, while they're on a transplant list to get an organ transplant. So palliative medicine runs concomitantly with what we would call aggressive treatment, or basically life-sustaining treatment, where end-of-life care and hospice, which I kind of equate to the same thing, where they kind of skew off is if somebody either forgoes life-sustaining treatment because it's causing more harm than good, or maybe there are no safe options available for treatment for that disease, and if we expect the disease to go down this trajectory of not having more than 6 months to live, then that's where the shift is purely to what we would call comfort care, and that is what hospice care is. So, and hospice, I don't know if you know, the Medicare hospice benefit was developed by the late President Jimmy Carter, who died on hospice recently at the age of 100, but that started in 1970. But essentially, both palliative medicine and hospice medicine run parallel in that we're both focused on providing comfort, best quality of life. But with hospice, for whatever reason, you're forgoing those life-sustaining treatments, including CPR, intubation, and sometimes other treatments, but it kind of gets a little gray in determining that.
So here's a question I have for all the physicians listening. Now that you say this, I can now rewind life and think about so many patients I saw that probably would have benefited from a palliative care consult, but I didn't even know that was an option. Or there were, honestly, there's not that many palliative care physicians, especially when we were coming up and stuff like that. Yeah. So when should a physician think about getting a palliative care consult? Is it when they're in distress, when they're in pain, or what is the criteria that we should think about to trigger, hey?
Sure. And I'll tell you, my most cringeworthy phrase is to hear they're not ready, as far as the patient isn't ready for palliative care. My answer to that is the moment that any kind of advanced stage disease is diagnosed, whether it's New York Heart Association class 3 or 4 heart failure, or COPD where you're on oxygen 24/7 and you're huffing and puffing, moving around your house. Or the American Society of Clinical Oncology stated in their most recent guidelines that within 8 weeks of an advanced stage diagnosis of cancer, they should be referred to palliative care purely for that support. They don't need to necessarily be in distress from uncontrolled pain or uncontrolled shortness of breath, and they're just in dire straits and maybe they are close to dying. The sooner, the better, because that introduction early on provides that level of support to know that they're not going on this journey alone. Sure, they've got their physician who's treating them. They've got their family members or caregivers that are important to them, but they've got an actual specialist who's going to be there every step of the way as they approach these obstacles to extending life in a meaningful way. The way I think of it is, I'm here to help you live with this disease, not die from it.
So I guess that's a big misconception. Palliative care, maybe people think, oh, that's the end.
Oh, yeah, they freak out.
Because we tie it to hospice or this or that. And so, oh, no, if you're going to get a palliative care consult, you're telling me my time is ending soon. And that's not the
It's
case.
not the case. Yeah,
Okay.
I do talk a lot of patients off the ledge when they hear what I do for a living. By the end, usually like, I'm so glad I met you because why didn't I get to see you sooner? Yeah.
So for people listening at home, they have a loved one that's diagnosed with cancer. When we were training, it's like you go to the surgeon to cut it out, the oncologist for chemotherapy, radiation therapy, all that. But there's another doctor, palliative care doctor, that can come in and help out. I imagine that the family needs to kind of be an advocate here. I mean, I don't
100%.
know how much, you think back in medical school and residency, I mean, palliative care is not a required rotation, so you may not even know about it.
No.
I had no concept till you have educated me on this.
Yeah.
So
The closest I got was like a geriatrics rotation.
Right.
And then there is some overlap, but I mean, no, not all the time.
Okay.
Yeah.
So maybe good to advocate for
Oh,
that
yeah.
and see.
And sometimes patients' families are the ones who, when I ask them, hey, do you know why you were referred to me? Sometimes it is the daughter or the spouse saying, well, she's in so much pain. She is not eating. She's fatigued all the time, and I need some help, with that. So a lot of times, the people who are closest to the patient are advocating on behalf of them to say, hey, we need some help.
And you're coordinating with the primary team, the oncology team, everybody,
Oh, yeah.
and then all the caregivers going out to the house, or if it's a consult in the hospital and all that sort of
Yeah.
stuff. Okay.
Yeah.
Okay.
I make it very clear that we are working together to make sure that, whatever your oncologist orders for you or whatever your cardiologist is proposing as far as a procedure, that all the facts about the procedure, all the potentials that could happen. And you also know that you have a choice in how we treat you. This is your body that we are treating, not ours, not your mother's or your spouse's. You're the one that's going to endure this. So you have to understand what you're about to put yourself through and just know that we are here to support you every step of the way.
Okay. So when they say, we'll get into a little more specifics of hospice, but when we hear end of life care, what does that mean relative to palliative care and or hospice? Or is
Sure.
there overlap, or is it?
Yeah, there is.
specific?
I mean, the fact of the matter is we are all going to find our end of life one way or another, whether it's walking outside and everybody uses the example of a car accident to, something more prolonged and arduous like dying from, metastatic cancer or dementias or whatever. So like I said, the vein that runs through all of them is just providing comfort and providing the best quality of life in whatever means that looks like. I guess I would think of like more end of life care would be, when somebody's more imminent. And that's where hospice care can come into the hospital and help support patients and families until their time, has, their time on this planet has ended and they die. There are inpatient hospice units, not too many in DFW, but there are some where patients can actually go into there, and it's a comforting environment with, one-on-one nursing so that they have all of that attention to their care as they transition towards death, just to make sure that it's the most peaceful possible.
When people go to inpatient hospice, you say hospice is 6 months. Is there, when you're admitted to the inpatient side, I mean, is it typically going to be less?
Yeah.
I mean, that's near
Inpatient,
the-
we're talking like days.
Days,
That's
okay.
the expectation. And here's the thing, and I tell this to patients all the time who are talking about hospice. There is no time limit, it's not like, okay, 6 months is completed, you're off hospice or you're supposed to be dead. No, patients actually, there are studies that show that patients with palliative medicine involved or even hospice care, their life can be extended and in very meaningful way, in that good quality way. I use Jimmy Carter again as an example. I mean, he was on cancer he was on hospice for like, I think 2 or 3 years. And the thing is, there are requirements through CMS, through Medicare that say, okay, you got to meet these benchmarks to be eligible for hospice. But, as long as there is a need, as long as there's a symptom that needs to be supported and managed, patients can stay on hospice service and continue to get those benefits for well beyond 6 months.
Yeah. Okay. So, I remember having this conversation with you, with my father who was on dialysis. and in the hospital, and we wanted to bring him home. And, I remember calling you and talking about, hey, he wanted to do home dialysis, but then we were talking about putting him on hospice. So once you trigger the hospice, then all that dialysis and all that stops.
Sometimes. So, and I would say Medicare's gotten more expansive in making sure that patients are globally cared for, and that can mean lots of different things. So, sure, there's a diagnosis that a patient gets admitted with. Let's just use metastatic cancer, for instance. But let's say they also had end-stage renal disease and were on dialysis 3 times a week. There is this kind of scrutiny that has to happen not only with the hospice agency, but also with the patient and the family too, just to determine, okay, I've got this metastatic cancer. I'm not on any sort of chemotherapy because it's just too toxic for me. So I'm just going to live out the rest of my life, however long that is. But dialysis is an important part of keeping me alive as well. Some patients would say, well, I want to continue it because, I want to still live, but I understand that, I don't have long. And that's a discussion between the hospice and the patient, because technically anything that could affect the prognosis of a patient has to be covered by the hospice agency. So that might include dialysis, that might include antibiotics, and that's okay, because infections can definitely cause suffering. They can cause pain and discomfort, and so hospice agencies will be responsible for taking care of infections, even wound care. But I circle back to how much of this intervention that you're asking for, like let's say IV fluids, or even feeding, like artificial feeding through the gut or through IV. A lot of families will get distressed over, well, my mom isn't eating. She's going to starve to death. What are we going to do about that? And I circle back to say, how much of this is actually going to reverse the disease as the reason that you're on hospice? You know what I mean? So IV fluids aren't going to correct the cancer. Dialysis won't even correct the cancer. But without it, your life is going to be shortened. So it's like I said, it's gray. It's not black and white. Like, okay, once you start hospice, everything stops.
Right.
But in a lot of instances, we look at that. We look at those things and just say, okay, well, how much of this is important for you to continue? Because then if you're like, no, insistent, I want dialysis, or I want to still go to the hospital if I can't breathe, then we decide, okay, well, maybe this isn't the right time for you to consider hospice care. Maybe you're still of that mind that I want to, seek aggressive life-sustaining treatment. And if that's the case, then you need to get back with your primary care doctor or your specialist, maybe find some kind of palliative care for you, outpatient or in-home, to support you so that you can live as long as you, desire to live the best way,
So you can go on hospice, you can go off hospice. One thing I've seen, from personal experience and I hear from patients sometimes is hospice can trigger a lot more care in the home that's covered, like caregivers. What all is that?
Yeah. So just like palliative care is multidisciplinary, so is hospice. So you're going to have physician, nurse, chaplain, social worker, home aide to come in and help with those activities of daily living. Social worker, if I missed that one. But there's a team that will actually come out to the home and provide care for patient and caregiver and family. And I also tell this to patients too. Enrolling with hospice is not a jail sentence. You're not locked in, forever. Patients do revoke and come off of hospice for various reasons, whether they fall and have a femur fracture and they're having so much pain they really need some kind of emergency care with an orthopedic surgeon, maybe to put in a quick nail and then get you home back on for whatever you were on. So you can come on and off. What I just say to that is, it's not encouraged to frequently come on and off. Let's say you have COPD and you're going back and forth to the hospital, so you're revoking hospice and going and getting some care in the hospital and then coming back home to get that extra care from hospice. That's not the intent of hospice care. It's really meant to just supply all of the care to you at home, knowing that, yes, eventually you're going to die from your COPD, and we're going to make sure you're as comfortable as possible.
Okay. So how can people advocate for, better access to palliative care
Sure.
and hospice?
Yeah.
What can they do?
Yeah, there's an amazing organization called the Center to Advance Palliative Care, or CAPC, and they have a public-facing website called getpalliativecare.org, and it's very easy to read and navigate, but it just has great information. There's also in the U.S. legislation, there's a bill that's called, we call it PACHITA, but it's the Palliative Care and Hospice Education and Training Act. Like I said, earlier, there's such a paucity of specialists in palliative medicine, and not even just physicians. We're talking about advanced practice providers, nurses, social workers, psychotherapists, anybody, you name it. They just have, we don't have enough to help out patients in our population's aging. We're still sick. Technology is great in the medical field, as far as treatments and extension of life. But people are eventually going to die, and their function is going to decline, and they are going to experience symptoms that induce suffering and distress. And we need more providers in this area. So my hope is that policy passes, and we get more education for physicians, and which is why I love working with the medical students and residents when they come through, and even if they have like a week or two with me, I think their jaws drop at the kind of conversations that we are able to have with patients, and really getting to know what's bothering them. How can we help?
Has telemedicine impacted your, hospice work and all that?
Yeah, it's impacted it in a good way. It's even like in the palliative care world. Like I said, I am the palliative care physician for all of our DFW clinics with the center. In fact, this morning I was in McKinney and Plano visiting a couple of clinics, and I'm not going to make these people drive to Fort Worth to see me in person. But there are studies that run through different palliative care organizations that show that even telemedicine, we can still touch lives. We could still reach people and address their needs and make sure that they feel supported. And fortunately, we're still able to do that.
You hear about these, the politics of medicine and taking telemedicine away, but when you don't have enough palliative care physicians, you have patients suffering.
Sure.
This seems to be like a great avenue for them to reach out to physicians like yourself.
Yeah.
So, okay, well, this is really enlightening.
Good.
I learned a lot. So, palliative care, end-of-life care, hospice, you've explained it extremely well.
Thanks.
I hope our listeners took a lot out of that. I think this is actually valuable for students, residents, interns, physicians, family members. This is...
Don't be afraid of it. There's nothing to fear. I joke that, they should call me Dr. Feel Good, because I'm going to make sure that patients and families feel good while they're on their journey with the disease that they have. So, yeah.
No, I appreciate you coming on. You're a colleague, you're a good friend of mine. Do a lot of work on other projects. You have a heart of gold, and I'm lucky to know you. And thank you for spending, your afternoon with us to tape this for, the good of our community.
Yeah.
So I appreciate it.
You're a mentor of mine and a great friend too. I remember rotating with you as a med student and learning so much from you, and to be here, this is just an honor. So thank you.
No, thanks for coming. So that wraps up our episode here. I think that was a fantastic episode. I hope you enjoyed it as much as I did. Please tune in to our various social media outlets. We're on X, we're on Instagram, we're on Facebook, we're on Twitter. Follow Tarrant County Medical Society for more podcasts to come down the road. Thank you.